Lucy Brooks from UCL, and she's going to tell us about causes and consequences of differentiation in glioblastoma. Thank you, Lucy.
Okay, good afternoon. So I'm Lucy. I'm one of the Career Development Fellows for RadNet, and I'm based at the UCL Cancer Institute within the Paranoid Lab, where we focus largely on understanding various aspects of neurogenesis and brain cancer. And my work in particular has focused on understanding the role of differentiation in glioblastoma. So glioblastoma is the most common and aggressive primary brain tumour. And these tumours are incredibly resistant to therapeutic intervention. So despite surgical resection, chemotherapy and radiotherapy, tumours will inevitably come back. And this leads to a really poor 5-year survival of around 5 to 10%. So it's important that we understand the mechanisms that underlie resistance. And one factor we know plays a very important role is the presence of a subpopulation of cells called glioma stem cells, which themselves are resistant to chemo and radiotherapy, and they are believed to drive tumour growth and recurrence. So similar to normal neural stem cells, glioma stem cells like the apex of a hierarchy whereby they can self-renew, but they can also differentiate. And similar to normal neural stem cells, which differentiate to form astrocytes, neurons, and oligodendrocytes, glioblastoma stem cells can at least partially differentiate to form cells that resemble the normal lineages of the brain, but in a more progenitor-like state. And now it's not quite as straightforward as this. We also have a subpopulation of mesenchymal-like cells, and these probably represent a more reactive-like state, and they've been recently linked to immune infiltration and inflammation. And on top of this, there's also a lot of plasticity in the system. So not only can cells differentiate, but they can also de-differentiate and transition between states. But if we could understand the factors that cause cells to differentiate or de-differentiate, we could potentially manipulate these to drive cells into a more tumour suppressive, more therapy sensitive state. So what does control differentiation? Well, as I alluded to with when talking about the mesenchymal cells, the microenvironment plays a really important role. And we know from the literature that both regions of hypoxia and angiogenesis can both drive cells to a more stem-like state. But the majority of studies have really focused on understanding the bulk of the tumour. And as you can see from this image here, where I'm showing you one of our PDX models, where the tumour cells are shown in green, these tumours are incredibly invasive. And you can see here they've invaded throughout the hemisphere and even across to the contralateral hemisphere. So these cells are exposed to very heterogeneous different microenvironments. And it's important that we understand the impact of these microenvironments, because these are the cells that are going to be left following surgical resection. And one of the main ways cells invade is via the white matter. And here I've just highlighted the corpus callosum, which is one of the major white matter tracts within the brain. So we wanted to understand what impact does the white matter have on the tumour. And what we found, and this is again cutting a long story short, is that as cells invade the white matter, they undergo this oligodendrocyte-like differentiation. And this differentiation is driven by a transcription factor called SOX10. And that's about all of the mechanism I'm going to talk about now. And rather what I'd like to do is focus on the consequences of this differentiation. So as cells mature, they become less proliferative. They also become less migratory. So we reasoned that if we could drive differentiation, we could push the tumour to a less proliferative, less invasive state. And this is exactly what we found. Here you can see on the left-hand side one of the control tumours. Again, the tumour cells are shown in green, and you can see them invading throughout the hemisphere and across, again, the corpus callosum. In the SOX10 overexpressing tumours, you can clearly see these are much smaller, much less invasive. And if we look at this in more detail, you can see that looking at EDU incorporation as a measure of proliferation, that these tumours are much less proliferative. And if we isolate cells based on their expression of O4, which is a marker of the pre-oligodendrocyte states, so slightly more mature, these cells are less migratory in vitro. But most importantly, what we find is if we drive differentiation, we can extend survival. So in summary, actually one thing I want to point out is that in this SOX10 overexpression group, the ones that did develop tumours, most of these cells were low or negative for SOX10. So it's really the escapers that were driving tumour growth. So differentiation is tumour suppressive. And it's not just that we've shown this for oligodendrocyte differentiation, but this has also been shown for more neuronal-like differentiation. So at least pushing cells towards these more differentiated states is tumour suppressive. But could this have additional consequences for radiotherapy? We believe this could be the case. So as I mentioned at the start, glioma stem cells are more resistant to therapeutic intervention. And specifically for radiation, it's been shown that these CD133, which is a marker of stem cells, these CD133 positive cells can preferentially upregulate the DNA damage response. And this leads to faster resolution of double-strand breaks. And these CD133 positive cells are enriched in the patient tissue following radiation. We also know that a separate, or I shouldn't say separate, but another population of glioma stem cells, so CD44 positive, more mesenchymal-like stem cells, are also radioresistant. So what we think is that if we could drive differentiation, we could potentially push these cells to a more radiosensitive state. And this is really what my work is now focusing on, is understanding whether or not this is true. And if so, I also want to understand the mechanisms that underlie this differentiation, the signaling events, so that we have options for radiosensitizing tumours. And that's it for me. I'd just like to acknowledge everyone involved in the work and ongoing collaborators, and especially Simona for all of her support, as well as CRUK RadNet. And questions?
Thank you, Lucy. That was terrific. Any questions? Got a question from Eric.
Hi, that was great. It's Eric Sahai from the CRUK. So just a question about these different sort of populations that the cells can enter. Do you know if they express things like POLQ at different levels or different sort of DNA repair molecules?
I've actually not looked in too much detail at that side of things, but it wouldn't be too hard to look at that. There's been single cell sequencing studies that do look at the expression in these different populations. So yeah, I could look at that.
Sorry, it's not a general question. How much do we know about how glioblastoma spreads in the brain with regards to metastasis? So you were talking about white matter, and you were talking about how blood vessels might be associated. Breast cancer metastasis to the brain, really disastrous.
Yeah, so I don't know much about metastasis from other types of tumours. In regards to GBM invasion, we know some. We know that their chemokines are involved. We know that cells, the main routes of invasion are either via the white matter, which we actually don't know too much about the invasive mechanisms. That's what we had intended to answer originally, and we ended up finding this differentiation phenotype. Along blood vessels is another key route of invasion, and we know some of the molecules involved in that as well.
So I was just wondering if the metastasis somehow affects the oligodendrocytes in the brain to affect stemness or not, whether there was that sort of crosstalk.
Oh yeah, that's a very good question. So actually, I didn't go into the mechanisms, but what we believe is driving this differentiation is it's a response to the damage to the microenvironment. So we're seeing an injury in the white matter, and that itself is what's causing the differentiation. It's almost like the tumour cells are trying to differentiate to repair as they normally would. So it's like a regenerative response almost.
Yeah, you're not the first person to think about wound healing and cancer.
Yeah, it's a really interesting topic.
Okay, I think we have an online question. Eric's going to read that out.
Yep, there's a couple. One from Anthony Chowder, the name's cut off, maybe Chalmers. Very interesting work. I'm wondering how your hypothesis relates to the observation that GBM tends to recur within the maximally irradiated volume, even though they are very infiltrative.
That's a good question. I mean, I guess you could argue that if these invasive cells are becoming less tumorigenic, it's the ones that are closer to the bulk of the tumour that are likely to form the secondary tumour. And if we could understand the mechanisms that are driving differentiation, hopefully we could enforce that on the ones that aren't necessarily exposed to the white matter. I hope that answers the question.
Thank you. And a kind of question or comment from Stephen Turnock that I guess relates to your central hypothesis. Will driving GSC into different populations change their radiosensitivity, i.e. are the oligo-like more radiosensitive compared to the mesenchymal-like?
Oh, that's a brilliant question. That's what I'm aiming to find out.